gosh, pain in my stomach. I should go doctor.
Good morning, Miss. How do you feel today?
I'm okay, but I feel pain and that at my abdominal area.
The nurses told me that you haven't passed scans since the surgery 3 days ago, right? Do you have the urge to defecate?
No.
No? Okay, so based on your symptoms just now, you have difficulty in moving as well as having discomfort in your abdominal region. I suspect that you have paralytic Ileus because you don't recover even after 3 days of surgery. So I will prescribe some medication to treat the discomfort that you feel right now. Ipa, I have a patient diagnosed with paralytic Ileus, but I would like to know your opinion on what would be the best medication to be used to treat her.
Actually, in the case of paralytic Ileus, the causes need to be considered first before dealing with any medication. Since there are different causes of paralytic Ileus, so the medication approach to treat paralytic Ileus also might be different. Basically, it was determined based on the pathogenesis. So, to treat paralytic Ileus, I would suggest Neostigmine, erythromycin, and also ibuprofen. For Neostigmine, it is associated with acute colonic pseudo-obstruction. Neostigmine is acetylcholinesterase inhibitor, so it is meant to facilitate the activity of acetylcholine and enhance the intestinal motility. Meanwhile, if the medication is the cause of paralytic Ileus, patient should be prescribed with another medication to counteract the action of paralytic Ileus. Basically, anesthesia was given to the patient before undergo surgery. So, anesthesia will bind to the opioid receptor and cause intestinal agony. So, we should give the patient ibuprofen. Ibuprofen will bind and block the opioid receptor and will stimulate again the action of colon. Okay, the last one is for erythromycin. It is used for the post-operative Ileus due to the functional dysmodality. Erythromycin is the proteinating agent, so it will bind to the motilin receptor and it will enhance back the action of the intestinal motility.
Okay, so the patient I mentioned just now, she has functional dysmotility, and from your explanation just now, I think that Neostigmine would be the most suitable medication to be used to treat her. What do you think?
Okay, let's move to the next lesson, which is acetylcholinesterase inhibitor. Any of you remember what is the function of acetylcholinesterase?
Okay, basically, acetylcholinesterase is an enzyme that catalyzes the breakdown of acetylcholine. Acetylcholine acts as neurotransmitter. Acetylcholinesterase is mainly found at neuromuscular junction and chemical synapse or cholinergic tie. The function of acetylcholinesterase is to hydrolyze the acetylcholine to choline and acetate. So if the acetylcholine is not destroyed, it can return to reactivate the cholinergic receptor and increase the cholinergic effect.
Okay, good, Alibah. And today, for the agent of acetylcholinesterase inhibitor, we will learn about Neostigmine. Basically, Neostigmine was found about 100 years ago.
There was a research about chemical basis of physostimulant by Stedman and Associates. Physostimulant ability to cross the blood-brain barrier has led to renewed interest in this molecule. In the research, Schliemann and Reiner were investigating about a series of substituted phenyl ester of allyl carbamic acid in phytostigmine. They found that neostigmine is the most promising member in the series, but with a much simpler structure. In the same year, it was introduced into therapeutic for its stimulant effect on intestinal tract. Okay, Dr. Reina, since we already found the most prominent member in the series, which is neostigmine, can you explain me about how the neostigmine differ from the phytostigmine?
Oh, I think doctor, there is no actually huge difference between phytostigmine and neostigmine, as neostigmine retains some part of functional group of phytostigmine, such as benzene ring, carbamate group, and the nitrogen of the first heterocyclic ring. And then the distance between this quaternary ammonium structure and the carbamate ester make it more similar or make it same as that found in the acetylcholine. And I think I would like to share about how this modification make it more neostigmine better than phytostigmine. Firstly, the introduce of the quaternary ammonium group make it doesn't cross the blood-brain barrier. This is important as this drug cannot cross the blood-brain barrier, thus it prevent the CNS side effect.
Okay, understand.
Okay, then the distance between this quaternary ammonium ion and the benzene ring is the direct binding of this functional group make it is reduce the number of conformation that molecule can adopt. Thus, it retain this active conformation is retained when it approach to the active site. Next, the introduce of a methyl group on the carbamate ester make it more stable as compared to the phytostigmine. I think that is even three important that it make it different from phytostigmine.
Okay, three.
So, yes.
Okay, I understand. Then.
I think that's all.
Okay.
Okay, so neostigmine is acetylcholinesterase inhibitor. So when acetylcholinesterase is inhibited, there will be no breakdown of acetylcholine. So there will be increase of concentration of acetylcholine at the synaptic cleft, and when the concentration is increased, the stimulation at the muscarinic and nicotinic receptor will be increased. And in certain cases, like paralytic Ileus, when acetylcholinesterase is inhibited, it will cause the stimulation of parasympathetic effect in the GIT. Then the GIT will start to contract.
So, physically, I wonder how neostigmine can bind specifically to acetylcholinesterase. Can you explain?
I know one of you will ask this question. That's why I prepared this. Okay, imagine this is acetylcholinesterase and it will have serine residue and histidine residue on its active sites. Serine will act as nucleophile and bond to neostigmine by attacking carbonyl of neostigmine. And then histidine will act as base catalyst and remove the proton, making serine more nucleophile, more nucleophilic. Histidine also will protonate the alkoxy groups, making the alkoxy group better leaving groups. And then after that, the carbonyl of the neostigmine will reform and it will expel the alcohol groups. For the next steps, the acyl part of neostigmine will bound to the active site, and then the side chain will leave and replaced by water. Water will act as nucleophile and attack the acyl group of the neostigmine. Okay, basically water is a poor nucleophile, and histidine again will act as basic catalyst and remove its proton to increase the nucleophilicity of the water. The carbonyl group of the neostigmine will reform, and the serine residue will release, and the ethanoic acid will leave the active site. Okay, that's all for today. Let's end our discussion with the paper hall. Thanks for joining us.
I agree with you because neostigmine is categorized under safe profile drug because it does not cross blood-brain barrier. However, neostigmine has its own adverse effect. The most common adverse effect associated with neostigmine is increased salivation. When neostigmine is given to the patient, it will block the action of acetylcholinesterase. So, there are massive binding of acetylcholine to its receptor. So, it will trigger the action of muscular contraction that will lead to salivation. Does your patient was diagnosed with heart failure?
No, she does not have any history of heart failure.
Oh, so it was good because if patient was diagnosed with heart failure, so she required therapeutic drug monitoring because neostigmine will cause bradycardia. Oh, and also remember if the patient complained that she was suffering with abdominal cramp, so neostigmine should be given with atropine.
Neostigmine would be the perfect choice.